Assalamu alaikum. Bismillahirrahmanirrahim. I am Dr. Muhammad Talat, Assistant Professor of Radiology, Cairo University. Today, inshallah, we have VIVA session number 16, chest cases. Welcome to ERO, Easy Radiology Approach. If you want to interact with us, please find the link of our WhatsApp group or Telegram channel in the first comment of this video. Okay. Today, most of our cases today are complaining of dyspnea and sometimes or occasionally chest pain. Okay. Okay, go ahead.
So I've been provided with a frontal chest radiograph of a skeletally mature patient. On gross inspection, I can see that there are a few reticular opacities in the right upper lung zone. I do not see any cavitating lesion, any nodules, or any obvious consolidation. The lung volumes are largely preserved. The costophrenic angles are acute. I do not see any pneumothorax or any pneumoperitoneum. I'm looking at the cardiomediastinal outline. I do not see any obvious mediastinal lesion. Cardiac size appears borderline.
Okay.
I am now looking at the ribs. I can not see any obvious lytic or destructive lesion.
Okay, nice.
And the soft tissues appear fairly symmetrical. There is no significant abnormality or mass lesion. A female patient, I would be concerned that this could represent, with preserved lung volumes, few reticulations in lung fields bilaterally more in the right upper zone. This could represent lymphangiomyomatosis. If the patient has a history of
lymphangiomatosis. Why lymphangiomatosis?
Because I do not see, I see that the lung volumes are largely preserved, and I do not see any regular pattern of disease.
You mentioned before that we have apical zone reticulations.
Yes.
Okay, I think is it present on both sides or right side only?
I think they're present on both sides, but more prominent on the right side.
Okay.
Yes.
Okay, let's focus in this area again. Okay, is it reticulation only or something else? Besides the reticulation, you are right. We have reticulations. I think it's present more obvious on the right side, right apical lung zone.
Yes. Yes.
Okay. Do you have any associated abnormality?
I have a suspicion that there is some cystic lucency.
Yeah, you are right. Perfect. Very nice. Okay. You have cystic changes also. Besides the reticulations, how can we determine the cystic changes? By, you call it coma reticulations or something else. Here we have cystic changes.
Yes.
Sometimes these cystic changes don't appear very clear as cystic, but sometimes you can see it as coma-shaped reticulations. So we have reticulations, coarse reticulations with some cystic spaces. So what's in your mind?
So since the patient is presenting with shortness of breath, if there is any no evidence of fever, I would be thinking on the lines of cystic lung diseases with preserved lung volumes. So my first differential.
Okay, but if we have cystic lung disease, it will affect most of the lung fields. Is that correct? But this one is localized at the right apical lung zone.
Yes.
Fibrotic infiltrates with cystic changes. Do you have any other options?
I can also think of bronchiactatic changes.
Okay. Yeah, you are right. Okay, can we check the
chest lung window in the Excel slices? And I would first scroll through the images to orient myself, and then I will explain the findings.
Okay, can we focus on the right upper lung lobe to save your time and save time for the others?
Sure. So I can see that there are reticulations and fibrotic changes.
Yeah, you are right.
Paraseptal emphysematous changes or cicatericial emphysematous changes in the right lung area.
Yes.
And there is architectural distortion. So there are predominantly fibrotic changes and paraseptal emphysematous changes. This could represent sequelae of prior infective etiology, such as granulomatous lung disease, like tuberculosis.
Right. Okay, that's fine. Okay, so in the last session, I think we enumerated together the causes of apical lung zone fibrosis. And in this case, it's focal coarse fibrotic reticulations with some cicatricial bronchiactatic changes. This most likely, as you said, sequela of old granulomatous infection, most likely TB. And indeed, this one had history of TB in previous scans before. Okay, so I would like to highlight again how to be familiar to pick up any reticulations and cystic changes in the chest X-ray. Okay. Okay. Thank you so much, candidate number 1. Can we go to candidate number 2? We have an interesting case
Yes,
for
sir.
you. How are you?
Yes, fine, thank you.
Yeah, fine. Okay. Are you ready? Okay.
Yes, doctor.
Can you please send for me a request for remote control?
Okay.
Okay. This patient came to us complaining of dyspnea and occasionally chest pain. Yeah.
I will scroll from top to bottom first.
Yeah.
Okay. Okay. I can see. I'm not scrolling. Sorry, there is some lag on
No
my
problem. No
internet.
problem. I will scroll for you. Okay. I will help you.
Oh, yes, okay. So,
Yeah. Okay.
yes, there is diffuse bilateral, basal, mainly basal honeycombing, and diffuse interstitial interseptal thickening and
I
honeycombing
couldn't
and
hear
traction
you very well.
bronchiectasis.
Can you hear me, please?
Yes. Can you hear me now? Hello? Hello, sir. Can you hear me?
Can you please, uh, uh, candidate number 2?
Yes, Doctor.
Yeah. Your voice is not clear.
Now clear? Okay. If not clear, maybe some
Okay.
internet
Go ahead.
problems.
Okay.
Okay, there
Okay.
is
No problem. No problem. Don't worry. Okay. Go ahead.
okay, I think there is bilateral background of emphysematous lung changes. There is also mainly epicobasal interstitial fibrotic changes in the form of interstitial septal thickening and honeycombing and traction bronchiectasis, mainly in the subpleural and in lung basis, filling the costophrenic recesses. So I am thinking of maybe associated with collagen vascular disease. So I'd like to review the patient history, if any history of rheumatoid arthritis or lupus.
Okay. Okay.
Also, I would like to exclude the scleroderma associated. So I do not see any dilated lower esophagus.
Very nice. Okay.
I want to check also if the patient has cardiac history and on amiodarone therapy or any other medication,
Okay.
maybe.
Okay.
Yes.
Let's enumerate again. What did you say? You said that we have interstitial septal thickening. I would like to make it more precise. We have interstitial reticulations because it's not interlobular septi or septal thickening. It is reticulations, coarse reticulations. And these coarse reticulations, as you said,
Okay.
with apico-basal gradient, the apex is least affected and the base is
Yes.
most affected. And these reticulations are more pronounced at the basal lung zones involving the costophrenic
Yes.
recesses. This one is very important, as you said, and also involving the subpleural spaces and associated with traction bronchiectasis and bronchiectasis, and also associated with architectural distortion. You describe this one very well. You have only one missing point, one important missing point to finish your description. What do you have here at these spaces?
It's affecting the pleural recesses, filling the
What you have here,
intercostal
yeah,
spaces.
what you have here in
Cardiac
this,
size?
no, I'm talking about the interstitial itself. What do you have here at this area? What do you have here?
I think it's honeycombing.
Yeah, it's cystic honeycombing. Very nice. It's
Yes.
cystic honeycombing. Cystic honeycombing means that we have multiple layers of cystic spaces, and these cystic spaces has line, and it's in subpleural location, and multiple layers over each other, and this one represent cystic bronchiectatic changes. So we have cystic honeycombing. This one is very important. So which pattern do you have in this case of
It's
interstitial lung disease?
usual interstitial pneumonia.
Yes, you are right. Usual
UIP.
interstitial pneumonitis. Yes, you are right.
Yes.
Usual interstitial pneumonitis. Usual interstitial pneumonitis, is it clinical diagnosis or radiological diagnosis, or what do you have? What do you think? UIB.
I think it's UIP is in radiological diagnosis like is the same like this, affecting mainly
Should
the
you
lung
write in
bases
your
with
report?
honeycombing.
Should you write in your report UIB or pulmonary fibrosis or IBF, idiopathic pulmonary fibrosis? Which one is correct?
I think IBF if there is no reason, if there is no clinical reasoning, but
Yes, you are right. IBF, idiopathic pulmonary fibrosis, it is clinical term, not radiological term. UIB is a pattern. It's a pattern,
yes.
radiological pattern. So in our report, we should report this one. In our opinion, we should write that these features are consistent or are impressive of usual interstitial pneumonitis, UIB. Okay, this one is correct because I saw many times in many reports IBF. It's not your rule.
Yes.
Your rule is to determine the pattern. Is it UIB? Is it NSIP? Is it something else? Okay, so it's this one. This pattern is UIB because we have very characteristic sign, cystic honeycombing, besides the interstitial changes that we described before. Okay, so we have UIB, and after determining the pattern, you should search, as you said, for the cause. Do you have any sign of connective tissue disease? We don't have any dilated esophagus. So, is you right? Yeah, you are right. So, not scleroderma. We don't have any calcified plaques. We don't have any dense liver, as you said. This one we should check the density of the liver. Yeah, it's normal density. We don't have any dense liver. If we have dense liver, we should think for amiodarone. Also, we don't have any mastectomy clips or something like this that can raise possibility of mastectomy and chemotherapy effect and something like this. So in conclusion, we have UIB pattern. But if I wanted to add something in this case, look for this slice particularly. What do you think the cystic changes, the cystic honeycombing, which area are most involved here in this slice?
Anteriorly.
Anterior
yes.
part of the anterior lobes. Is that correct?
Yes.
This one is called
yes.
anterior lobe sign. Anterior lobe sign. Okay, this
maybe
one
there was an old
suggest,
respiratory stress. Yes.
This sign can suggest underlying connective tissue. Okay. This sign is called anterior lobe sign. Okay. So if we have cystic honeycombing more localized along the anterior aspect of the upper lung lobe, especially if we have this one on both sides, this one can raise possibility of underlying connective tissue disease. But we are not sure because we don't have any additional signs, but look for this area. Can you give me the hand, please? Yeah, this one. Look for this part of the scan. This cystic honeycombing is more localized along the anterior segment of the upper lung lobe. Okay. So in conclusion, we have UIB pattern. Connective tissue disease can be raised in this part of the study because of this sign. but we don't have any other signs of connective tissue disease or asbestosis or drug toxicity or something else. Okay, okay, that's correct. Also, we should search for any masses because malignancy is fourfold more common than the normal individual in any case of interstitial lung disease. Okay, that's fine. Thank you so much, candidate number 2. Can we go to candidate number 3, please?
Thank you.
Okay. Thank you so much. Candidate number 3.
Sir, Assalamualaikum.
How are you? Alaikum assalam wa barakatuh. How are you?
Alhamdulillah.
Are you ready?
Yes, sir, yes,
This
sir.
case came to us, I think this case is 95 years old, yeah? And she came to us complaining of acute dyspnea. Can you please send for me a request for remote control?
Yes, right. I have requested, sir.
Okay, yeah, go ahead.
Okay. Okay, so this is the axial CD chest of a 90-year-old patient who is presented with the I think acute dyspnea, you said, sir? Dyspnea.
Acute dyspnea.
Acute.
She came to the ER complaining of acute dyspnea.
Okay. Okay, I will just scroll down the images to get an idea and then we'll describe findings.
Okay.
Just put down, this is a axial CT chest lung window. I can appreciate there are bilateral pleural effusions, almost mild to moderate,
Okay.
slightly more on the left side.
Okay. Okay.
Sorry, sir. Atherosclerotic calcifications as well.
Okay.
I'll just look at the lungs if I could find any lung parenchymal abnormality. Grossly, the realized part of the lung is not showing any gross.
Okay.
Except there
let's
are
review the other Let's review the medicine window. Okay. If you want to scroll, I will make it larger for you. Okay. Go ahead.
Okay, sir. So this is a soft tissue window of the same patient.
Okay.
Yes. Okay, I can. So there is some some problem in scrolling. Sometimes it's
okay. I will scroll for you. Okay. Okay.
Yeah, please, sir.
To save your time, no problem. Okay.
Okay, I think there are some degenerative changes in the spine.
Yeah, you are right. Okay.
Heart size, as I mentioned, is normal. Bilateral kidneys appear small, slightly atrophic, small in size. Liver margins are smooth.
I couldn't hear you really. Do you have any other abnormality? Okay.
I just wanted to look at the aorta if there is any ascending, descending aorta, ascending aorta.
The aorta, yeah, you have atherosclerotic changes.
Yeah.
And the mural calcifications in the aorta, but otherwise we don't have any other abnormalities. Okay. Do you have any other abnormalities?
I'm just looking at the carinal level. If you can show subcarinal level.
Subcarinal level, okay. I think it's free.
It's okay. It's okay. Okay. I feel there are some high density. This is an unenhanced scan.
Yes.
Scan. I feel like there's some high density peripheral rim of high density along the ascending aorta.
Can you ignore the aorta itself?
Okay.
Can you check other structures?
Liver, hilum.
So I think there are. Yes, I think there is something. Will you please scrolling is a good bit fast. There, can I just slow down scrolling at the lower
Okay.
lung, at the lower lung
Mm-hmm.
level? Maybe something related to stomach. I would seen some abnormality.
I think the
Yeah,
stomach is
this
collapsed.
one. Okay, this is collapse. This appears
Yeah.
quite thickened, so I thought this might be the reason.
Maybe a small sliding head hernia. Okay, agree.
Okay.
Okay. But
Uh,
do we have any other abnormality?
okay, I'm
What's
just
your checklist? Can you
going to
review?
look
Yeah.
at yeah, I'm just looking at the breast shadows, which I
The breast shadow.
found
Okay.
is slightly asymmetric.
Mm-hmm.
And I will look at the there is some soft tissue thickening around the left side. Can you see
Yes.
this one?
Yes. Yes. You are right. You
Yeah,
are right. Yeah. We have a breast mass. We have a breast mass, and this breast mass ulcerating the skin. Look for
yeah,
this
there
one.
is ulceration and
Yeah, you are
irregularity
right.
overlying
We have
skin.
a breast mass on the left side, and this one proved to be neoplastic mass breast cancer.
Is
So it's finding without any symptoms, or the patient didn't inform us by any of these symptoms. But my message here is to check the chest wall and the breast in every case. Okay.
yes, sir.
This mass is ulcerating mass. Sometimes this abnormality can solve many issues in the scan. Okay, so please take care of the breast. We
Thank
we
you.
diagnosed many cases of breast cancer in
Mm,
CT chest, in CT scan of the chest. Okay, so
thank
the
you.
message here, is to check the breast shadow within your checklist. Okay, thank you so much. Thank you so much. We have a bilateral blue effusion, as you
There was
said.
some actually. I'm traveling, so there was some lag in the.
I can see that there is a tunneled catheter seen on the right side. Whether it's the tip, a distal tip seen at the cavoatrial junction, which is appropriately positioned.
Okay,
Um,
that's fine. Hmm.
Other than that, I can see that the left hilar appears enlarged in size as compared to the right hilum. Could be
Mm-hmm.
due to any left hilar node.
Yeah.
Other than that, I can see that there are some bronchiactatic changes seen in the bilateral upper lung lobes, more marked on the left side.
Okay.
Um,
Yeah, I think you got the
uh,
idea. Yeah,
yeah,
you got the idea
um,
of this chest X-ray.
yeah,
Hilum is very important in our checklist. The left hilum, as you said, it appears radiodense, as you can see here. The left
yes.
hilum is radiodense as compared to the right side.
Hmm.
Uh, your differential nose, as you said, maybe lymphadenopathy, maybe hilar mass.
Yeah.
Yeah, and this one proved to be bronchial carcinoma. So please uh, keep searching or keep examining the hilar shadows. Okay, should be
Okay.
symmetrical in its density, should be bifurcating, and always the time the left hilum is higher than the right hilum. Okay, can you keep with me, please? Okay,
Yeah. Okay.
okay, yeah.
Okay, I'm presented with chest X-ray frontal projection of a skeletally mature patient. Here I can see that there are multiple reticulonodular shadows seen in the bilateral lung fields, more prominent in the bilateral lower and mid lung zones. There is indistinct left cardiac border. There is slight volume loss seen. I can see a calcific density pleural plaque projected over the right mid-lung zone.
Right or left?
Left lung zone, yeah, left lung
Left lung
zone.
zone. Okay, okay.
Um, this is suggestive of underlying interstitial lung disease, and this
Mm-hmm.
calcified pleural plaque could represent asbestosis plaque. However, I would like to correlate with the history of the patient, any history of occupation, and
Okay.
also any previous chest X-ray if available for comparison. Otherwise, I will like to proceed with the HRCT for further evaluation.
Okay, so you said that we have a multiple reticular opacities. in both lung fields, more in the basal lung zones. And we have also something like leaf-like calcific shadow projecting over the left middle and the lower lung zone. And this one, as you said, can be asbestos calcified plaque. Okay, let's see in the CT, is that correct or not?
Okay, so
Okay,
on the CT scan, axial sections lung window, I can see that there is subpleural interstitial thickening, and there are also cyst formations and honeycombing seen in the basal and lower lung zones. There is no consolidation or any mass-like region seen, but I can see the anteriorly calcified pleural plaque along the anterior pleura on the left side. This calcified pleural plaque could be due to asbestos or could be due to any previous infection such as tuberculosis. I will like to correlate with the history of the patient, any history of occupation or previous infection, and I will like to refer the patient to respiratory team with pulmonary function test as the patient has developed
okay, that's correct. That's correct.
fibrosis.
That's enough. Okay, as you said, we have calcified plaque, pleural calcified plaque along the costal pleural reflection on the left side, and this one can raise possibility of asbestosis or asbestosis related disease. Yeah, and this one
This is
considered as
interstitial
secondary. Yeah, interstitial lung
traction,
disease.
bronchiectasis, and honeycombing and cyst formation.
Which pattern is this one? Which type of interstitial lung fibrosis?
This is honeycombing UIP pattern.
UIP pattern, yeah. So
Yeah.
we have in conclusion UIP pattern secondary to asbestos.
Asbestosis, yeah.
Asbestos related disease. Okay.
Which more commonly involves the mid and lower lung lobe.
Okay. And by the way, asbestos plaque all the time spare the
Phrenic
recesses. Okay, yeah. Can affect any part of the pleura, but sparing these areas. Okay, okay. That's fine. Thank you so much. Candidate number 4. Can we go to candidate number 5?
عفوا دكتور بس
نعم.
اكو كولابس بالرايت upper lobe. There is a collapse.
Which one?
This case.
This case.
Yes. In X-ray there is a collapse or in chest
Collapse
X-ray.
in the chest X-ray? In the chest X-ray. Okay. انت قصدك حاجه ده؟
Yes.
لا خالص ده it's not collapse ابدا. بص حضرتك شايفه ده بس مجرد بس الفيسلز او الميديستانيال فيسلز هي projecting more.
Yes.
So we have as you can see, we have enlarged right paratracheal stripe.
Yes.
But all the time, regarding this point, sometimes we have widening of the right paratracheal stripe. All the time, compare the density of the right paratracheal stripe to the density of the aorta. Okay. If the density is lower than the aorta, most likely it's benign. Okay. Not significant. But if the density of the right paratracheal shadow identical or similar or higher to the aortic density, so this one can reflect something significant. Okay.
Okay. شكرا دكتور.
عفوا. Okay. Let's go to the next case. Next candidate, candidate number 5. Are you present?
أني دكتور. السلام عليكم.
وعليكم السلام. أهلا وسهلا. اتفضلي هاي. حضرتك عايزة سكرول؟ اتفضلي من هنا. Can you send for me a request? If you want me to scroll for you, no problem. Okay, I will scroll. Okay, no problem. Okay.
This is CT axial section of the chest. The history بلا زحمة دكتور.
Dyspnea.
This is a CT axial section of the patient who presented with dyspnea, showing at multi-level lung window at multi-level, showing there is granulous opacity at the subpleural spaces with
very nice
with the nodular uniformly distributed over all the lung lobes with bronchiectatic changes.
Okay, very minimal bronchiectatic changes or bronchiolectatic changes. Yeah, you are right.
Yes, with
But it's very
some
minimal. Okay.
with some emphysematous changes.
Maybe. Okay. But the predominant features is, as you said,
Ground.
we have reticular opacities, subpleural reticular opacities with minimal bronchiectatic changes, more in the right basal lung zones. Okay. So what's your diagnosis?
Non-specific interstitial pneumonia.
Okay. How can you confirm?
I have to ask the patient history or the sign of if there is scleroderma. We have to look for the esophageal dilatation, or we have to exclude the rheumatoid arthritis for the any.
Okay, no, I want to ask you directly. How can we confirm our diagnosis NSIP, non-specific interstitial pneumonitis?
We depend on the patient sign.
In this slice.
Yes, we have to shift to the mediastinal window also to see.
In this lung window.
In this lung window.
Yes. I have a very specific sign.
Yes, because it is subpleural. Is no, non-specific is not affecting the subpleural space. It then usual interstitial pneumonia is subpleural. Non-specific is not subpleural.
Can you see this red line? Is it affected or not affected?
It's not affected.
Yeah, you are right. This one is called subpleural sparing.
Subpleural sparing.
Sparing, yeah. We have reticulations, you are right, at the periphery of the lung fields with relative subpleural sparing. Yes. Look for this scan, subpleural sparing, very, very thin line.
Yes.
Sparing, yeah, sparing the lung parenchyma. This one is very, very specific for NSIP, non-specific interstitial pneumonitis.
Non-specific interstitial
this sign can be present up to 30 to 40% of the cases. But once we have this sign, you can write it in a confident way. We have features suggestive of NSIP. And as you, in our routine practice, we should search for any signs of connective tissue diseases like dilated esophagus and also erosion of the clavicles and something like this. We will review this one at the end of this.
Occupation, yes.
Yeah, you are right. Okay. Thank you so much. Can we move to the next candidate, please? Do you want to take another case?
Yes.
Okay. Let's go by this case. Okay. This chest X-ray, this patient complaining of dyspnea also.
Chest X-ray, frontal chest X-ray of an skeletal mature patient showing obliteration of the left costophrenic angle. And there is enlargement of the left hilar mass, enlargement of the left hilar, and there is an linear shadowing extending from the hilar to upward to the upper zone of the left lung zone. There is an opacity also seen. يعني somewhat يعني the hard border is not clear. The left hard border is not clear, and there is an opacity obscuring the left hard border.
Okay. What type of opacity do you think? You have, as you said, we have very hilar mass, as you can see here, extending to the left upper lung loop. Okay. What else? You told me that we have another opacity silhouetting the cardiac border. I need more precise words.
Yes. There is an elevation of the left hemidiaphragm more than
very
the right
nice.
one.
Okay, perfect. Yeah, you are right. Is it considered as a benign features or malignant features? Diaphragmatic elevation.
Here we consider it as benign because I see all the diaphragm, but is elevated somewhat.
Okay. But what about the hilum?
The hilum, there is a mass really. يعني
It's enlarged.
maybe lymph node or a
Indeed, you are
mass.
right. You are
We
right.
have
You
to
are right. You are
confirm
right.
by
You are
CT.
right. So we have enlarged left hilar shadow. Also, we have left perihilar mass extending to the left upper lung lobe, associated with diaphragmatic copula elevation. So simply, maybe this one is bronchogenic
With
carcinoma, and this one
malignant,
hilar metastasis invading
with
the
the phrenic
mediastinum
nerve
with
palsy.
with secondary left side phrenic nerve force.
Yes.
Okay, yes, you're right. And this one indeed left side bronchial carcinoma. Okay, that's fine. Thank you so much. Yeah,
No CT
my point here is to check the hilum. As we said before, the hilum here is enlarged, bulky, and not bifurcating, and slightly dense as compared to the right side. Okay, okay, that's fine. Can we go to the next candidate? You are candidate number 5 or 6?
Yes.
Oh, okay, let's go to the next.
The CT scan axis lysis post-contrast study. This is the lung window in which I can appreciate that there is bilateral symmetrical ground glass haze noted in both lung parenchyma, both lower lobes with the bronchiectatic changes as well. Traction bronchiectasis is also noted. These are more pronounced in the mid and lower pole and in the mid and lower lobes and in the peripheral location as well. So I can also appreciate that there is subtle, no, there is no inter or intras lobular septal thickening is noted. No mass is seen, no consolidation is noted. So on these imaging findings, my diagnosis of bilateral symmetrical ground glass haze with bronchiectatic changes is it could be interstitial lung disease. It could be in the lower lobes, most pronounced is the non-specific or hypersensitivity pneumonitis.
Do you think is it hypersensitivity pneumonitis?
No, there is no lung nodules are seen and
okay,
bilateral symmetrical.
So let's agree together. Let's agree together that we have some kind of pulmonary fibrotic changes.
Yes.
Okay. The predominant features is ground glass.
Ground glass and bronchiectatic changes.
Yes, and the minimal bronchiectatic changes. You are right.
Could it be yes? Could it be bronchiolitis due to infection?
Do you have any cystic honeycombing?
Cystic honeycombing in the peripheral location is less likely.
Less likely, yeah, you are right. Okay, it's not so obvious. Okay.
Okay. Esophagus is also normal. There is no dilatation of the distal esophagus is seen.
Okay.
No pleural plaques are noted.
Okay. Okay. Let's again because you told me very good signs. We have ground glass opacities,
yes,
and the distribution is very important in this case. We have basal lung distribution for little bit subpleural. Okay, but we have the predominant features is ground glass, and for sure we have ground glass because we have dark bronchus sign. The density of the bronchus is much darker than the lung parenchyma, so we have for sure ground glass with minimal bronchiectatic changes and minimal reticulations. So, yes. Okay, how can we reach our diagnosis? We have minimal reticulations, predominant ground glass, minimal bronchiectatic changes.
If the patient is smoker, then I could think of
the patient is not smoker.
Okay.
No, this cognitive it's not in this pattern. This cognitive it will be very hiler in this area, but it's not. It will not involve the lung basis itself. But it's a very good option, really. This cognitive interstitial pneumonitis. Okay, we don't have also some cystic changes typical for the IB. But do you think is it? If I will tell you, is it UIB or NSIP? What do you think?
It could be NSIP,
yes,
but not UIP.
NSIP. Yeah, we have two types of NSIP. We have cellular type, we have fibrotic type. Okay, if we have cellular type, the predominant features will be ground glass, like this one. Okay, so this one most likely is NSIP, and this one indeed proved to be NSIP. Okay, so we have minimal reticulations, we have minimal bronchiectatic changes, we have predominant ground glass opacities, and the distribution is very important, basal distribution. So this one, yeah, maybe we don't have a very specific sign subpleural sparing as we saw in the last case, but this one indeed considered as NSIP, not UIP pattern. Okay, okay, can you keep with me, please? Okay, this patient complaining of dyspnea as well. This one is very important. Is okay. Can you please, take your time and let's focus again.
Okay, fine. So this is the CT scan thorax, exercises, pulmonary window, in which I can appreciate that there is architected distortion in the form of multiple reticulations, subpleural reticulations, and bronchiectatic changes with its traction and fibrotic bands as well. Lung volumes are reduced in size, and there are multi-level air trapping noted, predominantly in mid and lower lobes.
Very nice.
I can also appreciate cystic changes in the upper and the mid zone predominantly, suggestive of honeycombing in the basal region. Yes, on the right side there is also cystic changes noted.
Yeah.
So this pattern is likely usual interstitial pneumonitis.
But I want to tell you something. You told me that we have an evidence of air trapping. Really, I have a very little objection. We couldn't say air trapping in the inspiratory phase alone. Okay, so the best term here is mosaic attenuation. Okay, we have different attenuation of the lung here, to here, to here, to here. We have different attenuation. We have mosaic attenuation. Okay, how can we prove that we have an evidence of air trapping?
We can do expiratory view to confirm that is there.
This one is the expiratory phase. Yeah, you're right.
So yes, there are multi-level air trapping nuisances are noted, which is suggestive.
Now we have a sure evidence of air trapping.
Okay.
The mosaic attenuation becomes more accentuated. So we have something of air trapping with attenuated vessels inside the dark areas of the lung. So we have an evidence of air trapping besides these coarse reticulations. Okay, that's fine. Yes. Okay, so what's your diagnosis?
As this is the pattern of interstitial lung disease, predominantly usual interstitial pneumonitis. So I am thinking
this one is not UIP. UIP will not associate it with air trapping.
Okay. It could be due to previous hypersensitivity pneumonitis pattern.
Perfect.
Chronic.
Perfect. We have two types of hypersensitivity pneumonitis. What are these types?
Subacute and chronic.
In the past, we classified hypersensitivity pneumonitis into acute, subacute, and chronic. But now, since I think 2021, the classifications is different. We have fibrotic type and non-fibrotic type, and this one is the fibrotic type of hypersensitivity pneumonitis. So we have, as you said, we have coarse reticulations, coarse fibrotic reticulations, and the distribution is very important. The distribution of the reticulations and fibrotic changes very hilar, central, and extending to the lung base. You are right, and we have also some sort of ground glass, different densities of the lung, and mosaic attenuation, and we proved that this one is associated with air trapping. So once we have central lung fibrosis with mosaic attenuation, you should think for another etiology. You should suspect hypersensitivity pneumonitis. So you should ask to do expiratory phase. And this one, by the way, if you have a non-diagnosed case of interstitial lung disease, and this was a first scan for you, please do your best. If you need to do expiratory phase, you will do. If you are searching, for example, for subpleural sparing, you can ask to do bron CT to search for subpleural sparing in NSIP. In this one, you should suspect that we have some sort of air trapping. You should ask to do expiratory phase and prove that we have air trapping. So we have coarse reticulations, fibrotic changes associated with air trapping. The first option here is fibrotic hypersensitivity pneumonitis, and this one should be discussed with interstitial lung disease (INDT), and also you should search for an antigen. We have either extrinsic antigen or internal antigen or something. You should search for the antigen that can induce these fibrotic changes. Okay, that's fine. Thank you so much. Candidate number 7. Can we go to candidate number 8?
Yes, sir.
This one is the inspiratory phase. Okay. Look for these areas. You should think that we have ground glass, and this one is dark spaces and ground glass again, and sometimes the normal lung tissue in between. This sign can be. Do you know the name of these signs that we have different densities? Different densities in the lung. This one is called 3 density sign. 3 density sign. Okay. 3 density sign. If you do expiratory phase, look for this one. This dark areas is air trapping. Okay. This is like ground glass, and this one is more likely normal lung tissue. So we have 3 different densities in this one with accentuated air trapping. Look for the dark areas. It's more accentuated than the inspiratory phase. Look for the inspiratory phase. It's not so obvious. Do you agree with me? Now yes. It's so obvious. The lung tissue should be homogeneous, higher attenuation in the expiratory phase. This is the normal lung tissue. Once we have these different densities, so we have for sure air trapping. And look for these vessels, for example. You will see attenuated vessels inside, not like these areas. These vessels is not attenuated, but these areas is much lower attenuated in the air trapped areas. Okay. So we have any evidence of air trapping besides the interstitial fibrotic changes, we should think for fibrotic hypersensitivity pneumonitis. Okay, not UIP pattern. Especially, I want to tell you something also very important in this case. Look for the most lower cost of phrenic recesses. It's free, spared. Yeah. Look for this one. It's more or less spared, not like those areas. Now, I think we enumerated 3 diseases in the chest, sparing the costophrenic recesses. Costophrenic recesses. Can you help me? Yeah, we said now that asbestos, pleural calcified plaque, can spare the costophrenic recesses. Also, fibrotic hypersensitivity pneumonitis, sparing the costophrenic recesses. And in one of our previous sessions, we discussed Langerhans histotus. Very, very nice. Excellent. Yeah. Langerhans histotus. Those are the 3 diseases that spare the costophrenic recesses. Okay. Yeah. Remember this. Yeah. Remember this disease. Okay. Okay. Let's go to the next case. Yeah. Wa alaikum salam. How are you?
Yes, sir. I'm good. How are you?
This patient complaining of dyspnea. Okay. Okay. Can you please?
Yes, sir. Okay, this is a frontal chest radiograph of a skeletally mature patient in which I can appreciate that there are reticulonodular shadowing noted in bilateral lung fields, more pronounced in the basal region.
Yeah, very nice. Okay, go ahead.
And there is also a blunting of the right CP angle with loculated laminated pleural effusion along the lateral chest wall. There is also thickening of the fissures. And next, I would like to know the age and history of the patient. And
yeah, the patient is 55 years old and complaining of acute dyspnea. Okay. You told us very nice description. We have diffuse reticulonodular infiltrates, more pronounced at the basal lung segments, and these reticulonodular opacities silhouetting the cardiac and the mediastinal contours.
Yes,
okay.
Border,
okay.
So
what's your opinion and what's your next step?
Sir, I would be concerned about mm, sir, LCH, because it can have no, a nodulation as well as the
LCH,
reticulation.
Langerhans,
Yes, yes, sir.
but Langerhans
Uh,
can affect more the apical lung zones, not the
uh,
basal lung
uh,
zones, and should be smoker. And this patient is not smoker.
yes, sir. And the other possibility could be mm, um,
Can you check the CT scan of the patient?
yes, sir.
Okay. Okay. If you want to scroll, you
Yes,
have.
sir. Yes,
Okay,
sir, I
you
have
can
to
scroll
scroll.
from here. Okay.
Okay, these are Excel slices of the HRCT chest lung window,
Okay.
in which I can appreciate that there are subpleural reticulation noted
Mm-hmm.
along bilateral subpleural areas, more on the left side. And mm, okay, I'm scrolling caudally, and there is some mm, traction bronchiectasis, also seen in the
Yes.
bilateral lower
Okay.
lobes, and
Okay.
there is some ground glass haze, um,
Mm-hmm.
but reticulation is more pronounced, and
Okay.
mm, there is no evidence of any pleural effusion on either side or any consolidation, and there is some subpleural sparing noted along
For a
the
little bit. Okay.
yes, a little bit on the
Can you
left
check the
side.
other slices above and below?
Yes, sir.
Okay.
Mm.
But is it coarse
There,
reticulations or fine reticulations? What do you
so
think?
these are coarse reticulations.
Coarse
Uh,
reticulations. Okay. And with architecture distortion, more pronounced
yes, sir.
at the basal lung zones. Okay. You are
Yes,
right.
sir.
Okay.
And there is no evidence of any cystic lung disease. And there
Okay.
is also bronchiectasis noted um, in the right middle lobe.
Okay.
And
Can you check the mediastinal window? Okay.
yes, sir. Um, okay, sir. Now I'm able to scroll. Okay, I'll start scrolling from above till the caudal end. And in the mediastinum, I can appreciate um, calcification, atherosclerotic calcification of the
Okay.
aortic
Okay.
arch. And there is also calcified lymph nodes noted within
Okay.
the right perihilar region. And
Okay.
mm, okay, so I will be concerned about keeping in mind the interstitial lung disease pattern and this calcified lymph nodes. I would be concerned for mm, sar sarcoidosis. Um,
Can you search for the cause, please? We enumerated how to search for the cause. We have either UIB pattern or NSIP pattern, but I think it is toward UIB pattern. But how can you help me to search for the
yes,
cause
sir.
for this?
There are multiple causes for usual interstitial pneumonia pattern, such as
Okay.
asbestos-related pleural disease.
Okay, we don't
And
have any pleural
yes, sir.
calcified plaques. Okay, you are
Yes,
right. We don't have any
and
dilated esophagus.
no dilated esophagus, and the other thing is hyperdense liver, which I can
Okay,
appreciate
hyperdense liver. Yeah, you are right. Perfect.
yes,
Perfect.
which
Okay.
I can
What does
appreciate
it
in this
mean?
case. Sir, amiodarone toxicity.
Yeah, amiodarone toxicity. Yes,
Yes,
very
sir,
nice.
due
So
to
we have
any
interstitial
cardio.
lung fibrosis secondary to amiodarone toxicity. Yes, you are
Okay,
right. Very nice.
yes,
And by the way, this case, the amiodarone drug was stopped, and later on, the chest X-ray almost clear. This highlights how can you search for the cause and identify the cause correctly. You will help the clinician to
mhm,
solve the problem and manage the case successfully. Okay, thank you so much. Can we shift to the next case, please? Next candidate.
Yes, Dr. Hyde.
Yeah,
Candidate 9.
candidate 9. How are you?
Yeah, all good, Dr. How are you?
This okay. This let's start by a simple case for you. I will scroll it for you.
Okay,
Do you have any idea what is this one?
This is axial CT chest lung window, which I can see there's septal emphysema noted.
Yeah, which type of emphysema?
This is paraseptal emphysema. Hello?
Which type of emphysema do you think?
I think this is paraseptal emphysema.
Yeah. Yes, paraseptal emphysema. You are right. It's
Yeah.
not cyst can come because sometimes for the genius may couldn't differentiate between this entity, this both entities. This one is paraseptal emphysema, not cyst can coming. Okay, let's go by the next case. Okay. What do you think?
This is a frontal chest radiograph of skeletally mature patient
Can you
of
see
adult
this one?
patient. Yes.
Yeah.
Which I can see that there is a well-defined opacity noted within the right upper lung zone, next to the medially next to the trachea, paratracheal stripe here. Or
which side? Right side or left side?
Right side. But no, I think this is part of the rib.
Yeah. Okay.
Okay, so I will ignore that. I can see that there is a mildly elevated left hemidiaphragm.
Okay.
The both hilar appears symmetrical, not enlarged.
Yes.
No confluent consolidation or collapse in the lung.
Okay.
No. There is some left retrocardiac opacity noted.
I think this is the unfolded aorta. What do you think? Is this one?
No, that beside it, adjacent to it.
This one?
Yes.
I think this is normal bronchovascular markings, and this one, the left diaphragmatic copula is well defined. Nothing. If we have something in the lower lung loop, it will silhouette the left diaphragmatic copula. Yeah. So we don't have anything in the left basal loop. Okay. What else?
Okay, so no, the left costophrenic angle. No, it's clear. Okay,
it's
so
clear.
no pleural effusion. In my routine practice, I would like to zoom to check for pneumothorax, but there is no pneumothorax.
Yes.
Bilateral small cervical reps noted. I think this is. So then I will check the rest of the bones.
Well, the bones are clear. Yeah, you are right. You should check the bones, but I want to save your time. The bones are totally clear. Yeah. What else?
Bone are clear. So
we have
checking
yeah. You good. You enumerated before that we have elevated left diaphragmatic copula.
Yes,
yeah.
and
Okay.
there is absent
Do you
of
have
the
any
splenic
explanation?
absent of the splenic shadow. I can't see the spleen.
Okay, you're right.
And there is gas-filled bowel loops there. So there is, I think, I assume there was a splenectomy or.
Let's concentrate in the lung itself. Do you have? Yeah. Do you have something that can explain elevated copula?
Either the copula is has attraction from the lung by fibrosis, but
we don't have any.
Which I
we don't
can't
have
see. Maybe if there is a
you started by the lung ABCs. Yeah, you started by the lung ABCs, and you told me that we have something abnormal in the right side. What about the left side?
Okay, let me check.
Which one is abnormal? Because
I
your
think
eyes
the
was
left
correct
side.
at the start.
Yeah,
The left side,
the
yeah.
left side. There is soft tissue shadow seen on the left and
Yes,
the base of
you
the
are
neck.
right.
Yeah.
Yes, you are right. You are right. This is the lung apex on the right
Yes.
side. This one is clear, but we have here clear opacifications
A
of
pacification. Yeah.
left lung apex, and this one is very clear now. And
Yes.
also we have, do you know this artifact?
And also, doctor, the tissue shadow at the base of the neck
Okay.
is not symmetrical on the right side and left side. The left side
Yes, you are right.
is
This one is
more
enlarged. Yeah,
prominent.
you are right. Very nice.
Yeah.
Do you know this artifact or this sign? Companion shadow of the spine of the clavicle.
No,
It's lost here. Do you think? Do you know what does it mean?
Not really. No.
Okay, if we have air surrounding the clavicle from above, we should have this sign. Once we have lost this companion shadow, so we have something obliterating the air around the clavicle. So we have something like supraclavicular mass or left apical lung zone mass. Okay, very nice. Really, they did PET CT for the case and the supraclavicular mass, and this one was proved as, look for this one to help you. This is a thyroid gland. It's a very invasive thyroid gland mass invading the superior mediastinum. Okay. Let's go to the next case. Can you go to the next candidate? نعم.
هو التراكيا شفتت على الاكس راي ولا لا؟
التراكيا shifted يعني. Trachea is mildly shifted to the right side. You are right. You are right.
تمام.
Okay. طيب, let's go to the next candidate, please. Welcome. Candidate number 10. By the way, by the end of this session, inshallah, we will discuss in brief very nice approach. But let us continue our cases. Okay. Candidate number 10. Are you present? Candidate number 10. Candidate number 11.
Yes, doc, I'm here. 11.
Yeah, okay. Yes. Patient is complaining of dyspnea.
Okay.
And yeah, she had the history of melanoma.
History of melanoma. Okay.
Melanoma, yes.
I've been provided with frontal radiograph of mature skeletally patient, chest. This is a female patient.
Okay.
I can appreciate that there is evidence of bilateral lung reticulations. Bilateral lung reticulation, parenchymal reticulations noted within both lung parenchyma. It appears to be more on the left side.
Yes, you are right.
Extending.
It's not symmetrical. It is asymmetrical.
Yes.
Much more
Asymmetrical,
pronounced.
more on the left side. Yes.
Yeah. Okay. You are right.
It's caused the veining of the left heart border. With this also, I can appreciate that there is some air lucency noted within the apex of the left lung, which could be bronchiactatic changes or architectural distortion.
Okay.
I'm not sure about. I need to see it.
Okay.
Okay, when I'm looking for the both costophrenic angle, they appear normal, no pleural effusion. Just the heart border, as I mentioned, it appears to be veining in the left side.
So in conclusion?
In conclusion, it's asymmetrical reticulations or reticular lung disease affecting more the left side with patient with the history of melanoma. I want to do CT for this patient because I want to exclude lymphangitis carcinomatosis in a case like this. Okay. In the CT, I have been provided with axial cut for the lung window. I can appreciate that there is evidence of interlobular septal thickening. There is evidence also in the left lung with center lobular nodules.
and there is evidence also of interstitial reticulations in the upper lung that yes, okay. It appears to be in both lung, but it's very pronounced on the right one, on the left one, sorry. And in the right
Okay.
lung, I can appreciate that there is a peripheral. Can you slightly up? No, I think that there is a mass in the peripheral region. Yes, yes, it's
Which
subpleural.
which
In the right, in the right,
which sign?
yes, yes,
It's
in
right
the right.
one? This one?
Yes, yes, yes.
I think it's consolidative changes. It's not like
Consolidated.
mass. Yeah, it's
Okay.
triangular. Yeah,
Yes,
subpleural
yes.
opacity. I
With
don't
some
think.
air bronchogram.
Yeah. Okay. Yes.
Okay.
Okay. So let's.
It
Okay.
appears
So
to be
is it confirming
lymphangitis.
your diagnosis or?
Yes, yes, it's confirming that lymphangitis
Okay.
carcinomatosis.
Very nice. You are perfect.
Okay.
Really, you got the idea from the chest X-ray. We have unilateral coarse reticulations, and once we go to the CT, look for this one. This is the secondary pulmonary lobe, and this is reticulations or thickening of the interlobular septi. Look for this one, polygonal shapes. This one is different from the previous cases. So once we have thickening of the interlobular septi, we have a very nice differential diagnosis. We can discuss this one in a separate session. But at this point, we should ask yourself, is it smooth or nodular? It's nodular. It's not smooth. If we have a smooth thickening of the interlobular septi, this one can be pulmonary edema, but pulmonary edema should be bilateral rather symmetrical. But we have unilateral nodular thickening. Nodular thickening may be sarcoidosis, may be lymphangitis carcinomatosis. Okay, sarcoidosis, it will project from the bronchovascular interstitium towards the periphery, but here it's more at the periphery. So this one most likely lymphangitis carcinomatosis. By the way, lymphangitis carcinomatosis starts by smooth interlobular septi, smooth thickening of the interlobular septi. Later on, by desmoplastic reaction, it will be nodular. But the classic features is nodular thickening of the interlobular septi. Okay, so this one really we don't know the primary cause because melanoma it's not common to cause lymphangitis carcinomatosis, but should be this case needs interstitial workup to search for any primary cause. Primary malignancy. And this one classic. Look for the lymphangitis carcinomatosis. Very nice to see this one. Okay, thank you so much. Candidate number 11. Can we go to candidate number 12? Are you here?
Assalamu alaikum.
Wa alaikum salam. How are you?
Fine, alhamdulillah.
Alhamdulillah. If you want to scroll, I will make you scroll from here if you want.
Yes, sir.
You can send for me a request.
Yes, sir, I send.
Okay. Okay, this case, middle age patient complaining of dyspnea, and the chest X-ray showed an abnormal density, abnormal opacity. So we should,
Okay.
We requested to do CT scan of the chest.
Okay, I am provided with the HRCT chest of middle age, patient. First, I will scroll through the whole stack of the images. I can appreciate lucent area in the left lower zone, which has cystic spaces and few cavitations. It is supplied, I am tracing the branch. It is supplied by a vessel which is directly coming from the thoracic aorta. No evidence of air fluid level.
Okay.
No surrounding inflammatory changes in the rest of the lung parenchyma, and rest of the lung field are normal. Trachea, mediastinum, or pulmonary vessels, heart are normally opacified with the contrast. So,
amazing. Number 12. Amazing.
So, in conclusion, it's a case of intralobar pulmonary sequestration.
Okay.
I would take the history of recurrent infections if present, and I would like to compare the prior images if available.
Okay. Let's define what did you say now. We have look for the arterial supply. It's coming from
Yes,
the thoracic aorta.
thoracic aorta.
Yes. And the venous drainage, look for the venous
Venous
drainage.
drainage, yes.
Is
It's
coming,
draining
this one, the venous drainage is
yes,
coming
yes,
to
yes.
the pulmonary veins.
Into the pulmonary veins. It's an
You are right.
intralobar pulmonary sequestration.
Yeah, this one is considered as intralubar.
قال على اي اساس ده روسي
Can you hear me? Okay, let's review this case again. So we have focal area, focal hypodense area, located at the posterior segment of the left lower lung lobe. And this area is supplied by arterial supply from the thoracic aorta and venous return to the pulmonary venous system. So this one is considered as intralubar pulmonary sequestration, not extralubar. It's within the pleural reflection. It doesn't have a separate pleural space. So what do you think is this one? Candidate number 12. Can you unmute yourself again, please?
Yes, sir. It's a focus of infection due to
It's
recurrent
not
infections.
infection. Yeah, it's atretic bronchial division. Okay, and this one common association, and this secondary air trapping for this atretic bronchial division. Okay, so this, yeah, you can sometimes find something unusual. Please search for the arterial supply, venous supply for the lesion to check the full picture of the abnormality. Okay, thank you so much.
Thank
candidate
you so
number
much.
12.
Thank you.
Thank you so much. Can we go to candidate number 13? Can you give me the control, please? Yes. Candidate number 13. Are you present? Candidate number 13. Okay. Candidate number 14. Candidate number 14.
Assalamu alaikum, sir.
Walaikum assalam.
Candidate 13.
Number 14?
Yes, sir.
Okay,
Number
that's
13.
fine. Number 13, okay. No problem. Okay.
Yes, sir.
Tell me. Okay.
Okay. So this is sir, someone else is doing this.
Okay. Yeah, tell me.
So this is X-ray chest frontal projection of an adult patient. I can see that there is ground glass haze is with cystic areas seen in both lung fields, predominantly in peripheral and the basal distribution.
Yeah, very nice. Okay.
And I cannot definitely see the any reticular prominence. Subtle reticular thickening is seen in the lower lobes, in both lower lobes. Other than that, the heart size appears normal. There is unfolding of arch of aorta.
So you mentioned that we have bilateral cystic spaces with like ground glass opacities at the periphery of the post lung fields with some reticulations.
Yes.
And also these reticulations are present at the basal lung zones. Okay, totally agree. And I think all of the other structures are normal. So what's your opinion? And what's your
the lung volumes also appear slightly reduced. So I'm thinking in the line of interstitial lung disease. It can be due to usual interstitial pneumonia pattern.
Okay, what's your next step?
At the I would correlate it with HRCT images.
Okay, this is the HRCT.
Okay, so I can see that there is inter and interlobular septal thickening
Yes,
with the bronchiactatic changes, and in predominantly in the periphery, and there are also slight emphysematous changes in the upper lobes. Um, and there is also traction
Can you?
bronchiectasis and
I'm sorry.
honeycomb.
I'm sorry. Can you please repeat again? What did you say later in the last words? You told me that we have
There are
intralobular.
emphysem. Yes, sir.
Yes, you are right. Very nice. What type of emphysema?
Yes, sir. So this is lobular emphysematous changes.
Centrilobular. You are right. You are right. So I
Yes,
think you
sir.
got the idea, yeah, of this patient.
Yes,
We have
sir.
UIP pattern,
Yes, sir.
UIP pattern, as we
Yes, sir.
described in many cases before. But besides the UIP, we have centrilobular emphysematous changes. Look
Emphysematous
for the,
changes.
yeah, you
So
are
it
right. This patient, yeah, this patient is a smoker,
Sir.
and the diagnosis of this
Okay.
case combined,
Is combined
yeah, tell
pulmonary
me.
fibrosis and emphysema.
Yeah, you are right. You are right. Very nice. You are perfect. Combined pulmonary fibrosis and emphysema. You are right. This is really a new entity described
Yes, sir.
together. So in your diagnosis, you should mention both of these two pathology. Okay. Thank you so much. Thank you so much. Can you keep with me? Can you
Yes,
keep
sir,
with me,
sure.
please? Okay.
Yes, sir.
Okay. Can you tell me
Okay.
what do you see here in this case? Yeah.
Okay, I can see that there is a area of opacification seen in a right upper zone, and there is a non-visualization of first, second, third, fourth, of the right fifth rib.
Very
It
nice. Okay.
Yes, sir.
Okay. So,
Okay, no.
what's your opinion? Okay.
Okay, no pleural effusion is seen. The hilar appears slightly retracted, right hilar. So I'm thinking in the as it's it's causing dissection of the right fifth rib. So it's likely a malignant process. And second would be if any history of any prior resection,
Yeah, you're
or
right.
prior.
Okay. Yeah, you're right. خلاص.
Yes,
Just we would like to highlight to check the bony cage perfectly in any case. We have lytic metastatic lesion involving the posterior aspect of the right fifth rib. And we don't have really in this chest X-ray any sign for any primary malignant mass or something like this can explain this metastatic lesion. But all the time you should check the chest wall. Okay, thank you so much. Can we move to candidate number 15?
Sorry, sir. Just one question. There was some haze in the lung. Was it? I
It's
thought
not
that it was
significant.
lung cancer.
Nothing.
Okay. Okay.
No, no,
Okay.
no, 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 no,
Okay, sir.
no,
Thank
no.
you.
It's projection. Okay, candidate number 15.
Hello, sir.
Thank you so much. Candidate number 15. Hello, how are you?
Hey, hello.
Let's start by this sample case with you. Yeah, let's start by this sample case with you. Spot diagnose.
I'm seeing there is apparent left pulmonary artery passing behind the trachea.
Yes, you are right. Yes, you are right. This is the main pulmonary artery. This one is the main pulmonary artery, and the left pulmonary artery is coming from the right side, insinuating itself between the trachea anteriorly and the esophagus. And this one can lead to dysphagia of the patient. So this one is very important and very critical to diagnose this case. Okay, let's go by the next case. What do you think? Give me also an idea. What do you think?
PA view chest X-ray showing bilateral upper zone lung opacity. Both costophrenic angles are normal. Cardiophrenic angle is normal. Cardiothoracic ratio is normal. The bony structure are within normal limit. Apart from the opacity, I cannot see anything else.
Okay. Do you have any other abnormality? You told me that we have bilateral apical lung zone opacities. Do you have any idea?
Like it could be bilaterality and rather symmetrical, could be progressive massive fibrosis related to sarcoidosis.
Okay, what else? We have some sort of fibrotic changes in the bilateral apical lung zone, and I agree totally. You are right. Do you have something else super added?
I don't see anything else. I'm suspecting there is a cavitary lesion on the right side in the apical
Yeah, you are right. Perfect. You are right. Perfect. This is cavitary lesion. Okay, you are right. What do you have here in this cavitary lesion?
I suspect it's a fungal ball with air crescent sign inside.
Yes, you are right. Yes, you are right. We have air crescent sign in this cavity. So we have fungus ball. And this one reflecting, give me final.
Fungal mycetoma.
Mycetoma, yeah, you are right. Okay, yes, you are right. We have bilateral apical fibrotic changes with mycetoma on the right side. And as we said, that mycetoma can develop on top of old tuberculosis infection, sarcoidosis, or something like this, the upper lung zones. And we have a classic mycetoma appearance, fungus ball within the cavitary region. Okay. What do you have here? Can you give me any idea?
From PA chest view, chest X-ray, the patient have a pacemaker. It's a double lead. There is an opacity seen at the right upper lung zone. The left hemidiaphragm is elevated. Cardiothoracic ratio is within normal limit.
Okay.
There is shoulder joint arthropathic changes. No pleural effusion. Both phrenic angles are clear. The leads. I cannot see anything else. There is just
okay. You told me that we have a pacemaker in its place, and once we have any pacemaker, you should tell me that we don't have any break or pneumothorax break in the leads of the pacemaker, and also we don't have any pneumothorax or something like this. But you have right apical opacity, nodular opacity, projecting over the right upper lung zone. What do you think? Do you have any idea for this mass or this opacity?
I'm suspecting it's a pleural based on the periphery and wide base. Like it could be pleural fibroma.
How can you be sure that this one is not pulmonary and pleural in origin?
Like based on its broad base. And
okay, it's a broad base. You are right. Okay, but we have here.
The lower
we have here.
The lesion has obtuse angle.
Yeah. Okay, you are right. Okay, agree. Totally agree. But we have a very specific sign here. We mentioned this one in the last session. Do you remember this one?
No, sir.
Okay, this one, as you can see here, this is the lower border. It's well defined. And this is the upper border. Not well defined. It's ill defined. This one is called incomplete border sign. So once we have any mass or nodule projecting over the lung field, you should search or you should check the borders. Okay, because this one is this one interface with the air well defined, and this one not interfacing with the air ill defined. So this one is called incomplete border sign. So this one, as you said, it's pleural in origin or chest wall in origin. That means that it is extrapulmonary. Okay, So let's check what is this one.
Okay, this is the axial cut CT chest showing expansile lesion originated from the rib. Seen homogeneous isodense density. It shows no aggressive features of invasion of the surrounding areas. Could it be like fibrous dysplasia?
Okay. Okay, it's one of our differential diagnosis, but fibrous dysplasia, the cortex should be well defined and surrounding the mass, but here it's punched out. The cortex is deficient, yeah, and also the age of the patient is elderly patient. The patient is it's above 60.
About multiple myeloma also we will think in older patients.
Which okay, multiple myeloma, you are very close, but it's not multiple myeloma. You are very close.
Other lesions that arise from the ribs are also chondrosarcoma, but I'm not seeing any chondroid matrix here.
Very nice. You don't have any chondroid matrix. Very nice. You are thinking very well. Okay.
Okay. I don't know.
Aneurysmal bone cyst, it's not a common location and it's not in this age group. Same bone cyst. Okay, I'm reviewing with you the expansile lytic lesions, giant cell carcinoma, giant cell tumor also it's not the case.
Askin tumor is far from diagnosis because
Askin,
the age
okay, but the age is different. Okay.
Yes.
Okay. What else? All the time we forget this diagnosis. Expansile lytic lesion in elderly patient or old age patient. Plasmacytoma.
Yes.
Yeah, plasmacytoma really, even me, sometimes I forget the plasmacytoma, possibility of plasmacytoma. It's not common, but yeah, it's not common, but it's you should put it in our
superior mediastinal widening with positive cardiothoracic sign. So it may be anterior mediastinal mass.
I think this widening of the mediastinum may be because of supine position. It's not very clear. Do you have any other findings?
Okay. There is maybe there is cardiomegaly.
Okay, agree.
With decrease the lung volume of the left side.
Okay. Do you have any other abnormality on the left side as you start to describe?
I think the left bronchus there is abrupt caliber change.
Do you have anything else?
Right pulmonary artery.
Can we because you are very close? Can you please focus again on the left side? You told me that the bronchus is amputated, but we have here some sort of
left hilar
air bronchogram. It's not obliterated, but it's very clear to see air bronchogram. What do you think? Can you check the diaphragmatic copy? Can you see the diaphragmatic copy?
No, it is okay. There is left lower lobe opacity silhouetting
Yeah, you
left
are right.
diaphragm.
We have retrocardiac left lower lung lobe opacity, silhouetting the left diaphragmatic copula with air bronchogram. So we have,
left lower lobe pneumonia.
yeah, you are right. Left lower lobe pneumonia. Very nice. Okay, perfect. What else?
There is maybe there is left hilar opacity.
Okay. Can you check the bones?
Okay. Clavicle no fracture. left lower spine silhouetting ribs no fracture in the ribs.
Can you check the dorsal spine?
Dorsal
Is it normal?
spine. Okay, there is maybe absent pedicle sign.
No.
No. Mm. Okay.
What do you think? What about the density of the bone overall? Is it increased or decreased?
Decreased.
Are you sure? I think the bones show slight diffuse increased density. Do you agree?
Okay.
Okay.
Yes, sir.
What is this
Maybe,
configuration of the spine? Do you know?
maybe there's increased density in the upper and lower vertebra and the plate.
No. This one is H-shaped vertebrae. Look for the depression here. Yeah, depression, central depression. Okay. What does it mean? Increased bone density with H-shaped vertebrae.
We can see this in the sickle cell anemia patients.
Yeah, you are right. This one is a sickle cell. Perfect. You are right. Perfect. Sickle cell anemia with lower lung lobe pneumonia. So, final diagnosis, acute chest syndrome. Okay, in a sickle cell patient. Yeah, you are right. Okay, so we have acute pneumonia on the left side with bony features or osseous features of sickle cell anemia. So this one can be keeping with acute chest syndrome. Okay, and by the way, we did the CT for the patient. This CT is 2 days before the chest X-ray, and the consolidated changes starts to appear. And let's see look for the spleen. I want you to see the spleen. Look for the splenic infarcts with calcifications. By the end or the end stage of this one is shrunken calcified spleen. This one is representing multiple splenic infarcts, splenomegaly with multiple splenic infarcts. So this is a case of
You mean autosplenectomy?
Do you hear me? Hello?
Yes, sir. I can hear you now.
Okay. So this one, yeah. So this one is a case of acute chest syndrome in a case of sickle cell anemia and with cardiomegaly. And this one is a common association in this patient. Okay. So let's go to next case. Who else wants?
Thank
who
you, sir.
else? Yeah. I need another candidate. Thank you so much. Can we go to?
Assalamualaikum, sir.
Wa alaikum salam wa barakatuh. Did you share with me before?
No.
Okay, let's go. We have another case. Very nice. Can you please send for me a request for remote control?
Yes, sir. Requesting.
Yeah. It's a very nice case for discussion. And at the same time, it's a relatively complex case. Let me zoom for you first. And okay, go ahead.
Okay, so I've been presented with axial CT in the lung window. First of all, I'm just going to scroll the whole images, then describe my findings. Here I can see that there is areas of ground glass opacities with nodular interlobular septal thickening is seen, which is involving the basal segments. Okay, I'm going opposite side. So there are areas of confluent nodular changes are also seen, which is more marked on the left side. And there is also loss of volume is seen on the left side.
Okay.
With mediastinal shift towards the left.
Okay.
I'm just going to check the rest of the findings. So there is also ground glass haze is seen, which is involving whole of the left lung. With peripheral reticulations are also seen, and there are areas of peripheral reticulations, and I'm looking at there are areas of subpleural fibrosis is seen, which is involving bilateral lung fields, which is more marked on the left side. So I'm in my routine practice, I'll also check the soft tissue window, as I can see that there are soft tissues in the bilateral hilar location and in the mediastinal pleura, I guess. So I will further evaluate this patient on soft tissue window.
Okay.
And there is also areas of focal bronchiactatic changes are seen, which is involving the anterior aspect of the right lung, the right anterior basal segment.
Okay.
And I can see that there is dilated esophagus with air fluid level in it.
Okay.
And so I will further evaluate this patient on soft tissue window.
Okay. Okay. Do you have any idea? What is this pattern?
This like it is involving basal segments more than the upper lobe. So there is apical-basal gradient, but there are areas of focal bronchiectatic changes.
Yeah, you are right. Okay. Do you have any cystic honeycombing?
There is more ground glass than cystic honeycombing, as I can see that maybe there are few like
there are few cystic honeycombing at the
Yeah.
most peripheral basal lung zones starting to appear. Yeah, you are right. Okay. Yeah. So you have bilateral coarse reticulations. Also, we have exuberant. This one is exuberant tubular cicatericial bronchiactatic changes.
Okay.
Also, you have starting to appear cystic honeycombing at the basal lung zones. We have ground glass. We have very small scattered consolidative changes in between. Okay, and we have dilated esophagus. So, in conclusion, give me diagnosis.
So in conclusion, as I can see, the dilated esophagus with non-UIP pattern, because we can see traction bronchiectasis, but as we can also see ground glass appearances. So NSIP and combined pattern with dilated esophagus. So this is scleroderma along with interstitial lung disease.
Okay, very nice. This X-ray for the same patient, X-ray hand.
Okay.
Is
So
it
I can see that there is
yeah.
So I can see that there is soft tissue at the tip of the fingers shows thinning, and I'm looking for the presence of any periarticular or soft tissue calcinosis. And there is also acrosteolysis, so this confirms the diagnosis of systemic sclerosis.
I don't think we don't have any gross acrosteolysis really.
Okay.
But we have some sort of deformity. Do you know the name of this deformity?
Yeah, because there is also a subluxation of the
you are right.
metacarpophalangeal joints.
Yes, you are right. You are right. We have subluxation and we have flexion.
It is Jacquard disease.
This one is flexion deformity because we sometimes have some deformity in the skin. Skin is rigid in scleroderma. It's a common association. And as you said, we have evidence of interstitial lung fibrosis. I will describe more in this details. Can you please describe with me? Can you please? I will unmute. I will mute. I'm sorry. I will mute all the participants and unmute yourself again. It's okay. Okay. Can you please unmute yourself again? Okay.
Yes,
okay.
I tried.
I will scroll for you. Do you have any other findings in this case?
So we can see that there is significant cardiomegaly as there is also secondary pulmonary hypertension due to increase in diameter of the pulmonary artery trunk. So there is increase in the ratio of the pulmonary trunk to the aorta. So it is more than one. Seems to be.
Okay.
And,
very nice. Okay. We have pulmonary arterial hypertension. Okay.
And there is also pericardial fluid.
Pericardial effusion. Okay. Very nice.
Yeah.
Okay.
And there is also ascites.
Okay. Do you have any explanation for this cardiomegaly in this case?
Because this is collagen vascular disease, so it may cause like or this can be secondary to lung disease, like
yeah, you are right. It can be secondary to the interstitial lung fibrosis, pulmonary arterial hypertension, and secondary cardiomegaly. Also, scleroderma can affect the myocardium itself, can make myocarditis and fibrosis in the cardiac muscles. So can explain cardiomegaly also as well. But let us review the case again with you. We have coarse reticulations, as you said, and these coarse reticulations associated with architectural distortion in the basal lung zones with bronchiactatic changes, cicatericial bronchiactatic changes, and starting cystic honeycombing changes at the most periphery of the lung zones with dilated esophagus. So we have these interstitial lung changes can be UIB pattern because of cystic honeycombing and exuberant bronchiectatic changes. But at the same time, if we have dilated esophagus, we should think of scleroderma. And scleroderma, by the way, 70% of the associated interstitial lung disease will be NSIP, not UIB. UIB in 30%. So we have different patterns, different points, interstitial changes keeping with UIB, but the age of the patient, I think 46 years old, more younger, with dilated esophagus, scleroderma. This one can be more common associated with NSIP. So in conclusion, we have two differential diagnoses, either UIB, or end stage NSIP. Yeah. Both of these patterns are very close, very similar to each other. So we have either end stage NSIP or UIB pattern. How can we differentiate? We should review the previous scan. Okay. In any case of interstitial lung disease, you should search for any complications. As you can see here, pulmonary arterial hypertension. You should search for any malignancy. We don't have any malignancy. Okay. So this case of scleroderma. Okay. Thank you so much. Let's go. Thank you so much. Let's go to our last case for today.
عفوا دكتور بس could be يعني superadded infection due to aspiration.
Yeah, you are right. You are right. These constitutive changes can be superadded infection. You are right.
Yes.
You are right. We described this one. Yeah, we have some scattered constitutive changes. Yeah. It can be aspiration pneumonia, can be organizing pneumonia, can be something like this. Yeah, you are right. Okay,
Doctor, may
let's
I
go.
have a question?
Okay, can you please describe what do you see?
There is a chest X-ray, AB view showing diffuse reticulonodular opacity involving the post-lung fields, and the opacity silhouetting the left cardiac border. Both cosophrenic angles are clear. There is no pleural effusion, and there is a diffuse decrease in the bone density. Also there is ده يعني التراكية مش قادرة أحدد فيه
I think it's a positional.
positional. Okay.
Yeah.
Okay.
Do you have anything else? You have, yeah, you mentioned that we have reticular nodule infiltrates, diffuse reticular nodule infiltrates.
Yes.
Maybe more pronounced at the basal lung zones. And this is an elderly patient, 80 years old.
Okay.
And do you have something else?
No, I can't detect anything. يعني هو
Can you
there is
check? Yeah.
the
Okay.
mediastinum is slightly widened.
Okay. What else? Can you check the lung ABCs?
There is يعني opacity in the left apex.
Left side? Left side is normal.
Okay.
It's not normal. We have, by the way, pulmonary fibrotic changes. Okay, but
okay,
we don't have anything more in the left side. Do you have something in the right side?
The drips may be abnormal. Drips,
okay.
There is a fractures.
Okay, let's check this X-ray for the same patient 2 days before.
Okay. There is a pneumothorax.
Yeah, you are right. We have pneumothorax on the right side, and I think it's here. It's a moderate pneumothorax, but here we have a mild pneumothorax. Don't forget.
Okay. Yes.
Yeah, you are right. Don't forget to check all your checklist, please. Okay.
I see
we have right
now.
side. Yeah, we have right side pneumothorax. Is it tension pneumothorax or not tension pneumothorax? What do you think?
It's not tension. يعني.
It's not tension. How can we identify tension pneumothorax?
Severe.
Yeah, you mean the sinus shift?
Flattening of the diaphragmatic copula.
Okay. And widening of the ribs. Okay. Don't forget this one. We don't have any significant widening of the ribs. We don't have any significant sinus shift. So this one is spontaneous pneumothorax. Okay. This CT scan for the patient. Okay. Let's review the patient. CT scan for the same patient. And I think it's very clear now to have UIP pattern.
Yes.
As you can see here, coarse reticulations and cystic honeycombing, and we have right side pneumothorax. I want to ask you 2 questions here in this case. First, do you have any explanation of pneumothorax in UIP patient?
Rupture of the cystic honeycombing.
Okay, rupture of the epiphyseal poly and cystic spaces. Okay, can be one of the explanation, but can you give me another explanation? By the way, we have this one is hydropneumothorax. It's not only pneumothorax, okay? But can you give me explanation for the pneumothorax in any patient of UIP? Okay, I will tell you. Yeah, the fibrotic tissue are more fragile in patients of UIP. So it's easily torn. Okay? It's rigid. It's not elastic. Okay, so it can be easily torn and induce or make pneumothorax, sometimes pneumomediastinum. Okay, this is the explanation for this one. And by the way, this patient presented to us in many times with pneumothorax. One on the right side,
Repeatedly.
and also I have many images for the patient with left side pneumothorax. Every time he came to the ER with pneumothorax on one side. I want to ask you something else. Can you see this one? We have exuberant cystic honeycombing. Do you agree?
Yes.
This
Yes, I
cystic
agree.
honeycombing, this cystic honeycombing involving more than 70% of the fibrotic lung tissue. Almost in this way, in this side, more than 80%, something like this, 80 or 90% of the fibrotic tissue. Almost all the fibrotic tissue show cystic honeycombing. Do you know the name of this sign?
No.
This one is called exuberant honeycombing sign.
Okay.
Exuberant honeycombing sign. When cystic honeycombing involves more than 70% of the fibrotic lung tissue, this one is called exuberant cystic honeycombing. And this one of the signs of connective tissue disease. Okay. So this one is considered something like this. Okay, let's. I think we finished our case today, and let's my checklist for any chest X-ray. For any chest X-ray, if you don't find any gross abnormality, you will start by your checklist. My own checklist starts by the mediastinum. All the time, I should see the trachea. I should see the aortic outline, the paraspinal outline, paratracheal stripe, left paratracheal stripe. I should check first the mediastinum. After the mediastinum, you should check the hilum. The hilum should be symmetrical in density between both sides. Should be bifurcating, as you can see here. Also, the left hilum is slightly higher in position as compared to the right hilum. And this one is very important in any case of upper lobe or lower lobe lung collapse. Next, you should check the bronchial division as much as you can. If there is anything or radiolucent foreign body or not, especially in the pediatric age group, then you can concentrate in the lung field itself. Both lung fields. Please check both lung fields, searching for any consolidation, collapse, nodules, masses, cystic changes, reticulations. And don't forget the lung apices and the basis of the lung. Sometimes you can find pulmonary opacity or pulmonary nodule projecting over the diaphragmatic copy. It can be in front or behind the diaphragmatic copy. Then you should check the bony cage, the ribs, the clavicle, the humerus, the scapula. All the bony structures you should check. Then you can check the soft tissues, nodules, soft tissue tumefaction, or soft tissue swelling. Then you can end by 3B and 3B. 3B, searching for any pleural effusion, searching for pneumothorax, especially deep sulcus sign, searching for any pneumomediastinum. Those are the 3B. 3B, behind the heart, check retrocardiac opacity, something silhouetting the left diaphragmatic copula. Check subdiaphragmatic below the diaphragm. Check the breast shadow. Is it present or not? So we have behind the heart, below the diaphragm, and the breast shadow. Please, if you need to check the reps, check for 3 points. Check for any fractures. Check for any lytic lesions. Check for any rib notching. So again, in your checklist, start from midline or medial to lateral. Start from the trachea. Start from the mediastinum, then hilum, then bronchial division, then lung fields, then osseous structures or chest wall, then the chest wall, soft tissue of the chest wall, then end by 3B and 3B. Pleural effusion, pneumothorax, pneumomediastinum, behind the heart, below the diaphragm, and the breast shadow. Are the breast shadows are present or not? If there is any evidence of mastectomy or not. Below the diaphragm, search for any gases in the liver, searching for any pneumoperitoneum, searching for any surgical clips for the adrenal gland, and all of these. I hope you got the idea. And I think all of you should have his own checklist. This is my own checklist. Maybe easy for you to apply. Okay, I think we discussed many times in many cases the UIB pattern, and this is NSIP pattern, fine articulations with subpleural sparing. This is another case of NSIP. Just to repeat it again, we don't have any exuberant bronchiactatic changes in NSIP, in the classic case of NSIP. Let's review our discussion for today. Okay, this is from Radiology Key website. We have different parenchymal patterns. We have either interlobular septal pattern, as we saw in cases of lymphangitis carcinomatosis, as we saw in our cases. Bronchiectatic changes, we saw this one besides cystic lung or cystic lung changes in one of our previous sessions. Today, we focused on the intralobular interstitial thickening or reticular shadows. Really, we have this article is very nice to review if you want to review. Really, I reviewed this one. It's very beneficial and informative. Let's focus in our presentation. Once we have any fibrotic interstitial lung disease, we have 4 possibilities. Usual interstitial pneumonia, UIP pattern, NSIP pattern, and also fibrotic type of the hypersensitivity pneumonitis. And also we have some sort of pleuroparenchymal fibroelastosis. This one is very rare case and considered one of the causes of bilateral apical fibrotic changes. Okay, please, before diagnosing any case of fibrotic interstitial lung disease, exclude that if we have any fibrosis in one part of the lung, as we saw in our first case today, old granulomatous infection. This one can be old infectious sequelae, and this one, it will not progress, but those patterns can progress. Okay. Hence, we have any interstitial lung fibrotic changes, you should think at the beginning, is it UIP or not? We have 4 different classifications of UIP, either typical 4, probable UIP, indeterminate for UIP, and non-UIP pattern. Typical UIP, you will find reticulations, traction bronchiectasis, and honeycombing. This one is very important, honeycombing. Cystic honeycombing. This one is typical for UIP. Probable UIP, the same, reticulations, peripheral traction bronchiectasis, and all of these features without cystic honeycombing. So if we have coarse reticulations with traction bronchiectasis, those features will be diagnostic for probable UIP. If we have subtle reticulations with mild ground glass, so the ground glass is not the predominant features, but we have subtle reticulations without any bronchiectatic changes, this one is indeterminate for UIP, and non-UIP pattern, any features other than reticulations and traction bronchiectatic changes. One cause by far is idiopathic, and this one what we called idiopathic pulmonary fibrosis. So idiopathic pulmonary fibrosis, this one is a clinical diagnosis. This is not your rule. This is the clinician rule. Idiopathic pulmonary fibrosis. Okay. Secondary UIP, maybe connective tissue disease, maybe drug-induced, maybe familial, maybe asbestosis. Okay, so you should search for the secondary causes of UIB. Once we have any secondary, once we don't have any secondary cause, you should consider this one as idiopathic UIB, idiopathic pulmonary fibrosis. Okay. UIB can show some additional findings, sometimes ground glass opacities, but it's not the main features. Diffuse pulmonary ossification and mediastinal lymphadenopathy. Sometimes we can see combined pulmonary fibrosis and emphysema syndrome. This one, we saw this one in one of our cases. We have some signs, as we said in one of our cases, anterior upper lobe sign. I have a case like this one. Once we have cystic honeycombing or exuberant reticulations or coarse reticulations in the anterior part of the upper lung lobe, this one is called anterior upper lobe sign, which can reflect connective tissue diseases. We have also exuberant honeycombing sign. We saw this one. And we have also straight edge sign. As you can see here, this is the cystic honeycombing, and this is a normal lung tissue. We have sharp definition between the abnormal and the normal lung tissue. This one is called straight edge sign. Sometimes in case of UIB with subpleural affection, sometimes we can call it lateral creep sign, because the straight or the edge that differentiate between the normal and the abnormal tissue take this lateral creep pattern. Okay, so we have three signs that can suggest underlying connective tissue disease, either in UIB or NSIP: anterior upper lobe sign, exuberant honeycombing sign, lateral creep or straight edge sign. Regarding NSIP, we have secondary NSIP. This one is the most common, not idiopathic, as compared to UIB. UIB is the most common, is idiopathic. NSIP, the most common is secondary NSIP, either connective tissue disease or drug related. The least common is idiopathic. We have two different types, hilar or fibrotic NSIP. NSIP, the distribution is very important. Lower lung lobe predominant. Ground glass is very common. Reticulations, it's fine reticulations, not coarse reticulations. Traction bronchiectasis, it's very minimal to see. How can we differentiate between UIB and NSIP? Regarding the age, UIB in older age group, likely idiopathic. NSIP, it's younger age group. Distribution lower lobar and subpleural in UIB, lower lobar in NSIP. Heterogeneous pattern, this one is homogeneous pattern. Subpleural sparing, as we discussed before, it's one specific sign of NSIP. It's present in about 43% of the patients. Honeycombing, it's very important to see honeycombing in patients of UIP. It's very rare in NSIP. Honeycombing versus ground glass opacities. UIP, degree of honeycombing much more pronounced than ground glass opacities. NSIP, ground glass opacities more common than honeycombing. Also, additional signs, lateral creep sign, more common than straight edge sign in any case of UIB. Straight edge sign is more common in NSIP. Mediastinal lymphadenopathy is less common in UIB and more common in NSIP. And by the way, as we discussed before, end stage of NSIP can be very identical to UIB. Fibrotic hypersensitivity pneumonitis. The distribution of the fibrotic changes can be diffuse, sometimes central, sometimes basal sparing. Lung fibrosis, reticulations, and traction bronchiectasis, we can see all of these features, but beside these features, you can see one of these abnormalities, small airway disease, either ill-defined central lobe nodules, and these central lobe nodules, by the way, it will be ground glass nodules, mosaic attenuation, and air trapping. The different mosaic attenuation, you can say mosaic attenuation in the inspiratory phase. Air trapping, you can say this one in the expiratory phase. 3-Dennis pattern, as we saw before. So if you have reticulations, coarse reticulations in central distribution or diffuse distribution, apical, near or similar to base, so this one is it's different from UIB. So you can think again, is there is any mosaic attenuation, is there is any air trapping, is there is any ill-defined central nodules, 3 density pattern, you should think for fibrotic hypersensitivity pneumonitis, not UIB. So this one is the most important slide here. Our suggested approach for interstitial fibrotic lung disease. Ask yourself first, is it classic or typical or probable UIB? If it is yes, okay, so you have UIB pattern. If it is no, you should think again, is it NSIP or fibrotic hypersensitivity pneumonitis? Basal with subpleural sparing, NSIP. Central distribution with mosaic attenuation or trapping, fibrotic hypersensitivity pneumonitis. If these findings are present, okay, yes. If is it no, it's indeterminate for UIB. If we have, for example, very fine subpleural, fine reticular pattern, you can say, in your opinion, it is interstitial lung abnormality for follow-up, because you are not sure, is it NSIB or UIB? Maybe the beginning of both, maybe beginning of NSIB or UIB, maybe fine fibrotic reticulation is very fine, not so significant. So this one is indeterminate for UIB. Any case of UIB or NSIB, you should search for secondary causes. You should search for any pleural calcified plaques, asbestosis, dilated esophagus, scleroderma. Search for any signs for connective tissue disease, as we said, anterior upper lobe sign, exuberant honeycombing, straight edge sign. Sometimes clavicular erosions, pulmonary nodules. You can think for rheumatoid arthritis, dense liver, drug toxicity, amiodarone toxicity, mastectomy, and axillary clips for chemotherapy. So, in any case of interstitial lung fibrosis, you should search at the beginning. Is it UIB pattern? Is it NSIB pattern? Is it fibrotic hypersensitivity pneumonitis? Which pattern? If you decide that is it UIB or NSIB, please start to search for the secondary cause. Is it asbestos? Is it scleroderma? Is it connective tissue disease? Is it dense liver? All of these issues, put it together and write in conclusion. In any case of UIB, in follow-up, you should search for any complications, pulmonary hypertension, pulmonary arterial hypertension, any nodules or masses, because the incidence of malignancy is 4-fold more than normal. Searching for any ground glass or constitutive changes because of superadded infection or organizing pneumonia, pneumothorax, as we saw in one of our cases. So those are the most common complications. You should search for these complications in any case of UIB on follow-up. By the end of the session, thank you so much. Thank you for the audience. Thank you for the hot seats. Thank you for all you all. Hoping you get benefit of this session, and see you in next session, inshallah.